Please. Okay. We basically going to talk about the lenticule-based surgery which is there, and I am just going to give you a brief overview. Though Dr. Shri Ganesh has already talked about the 800, I'll give you a brief overview on what are the present technologies that are available for refractive lenticule extraction. So, from a basics, I think. All of you know that the SMILE procedure stands for small incision lenticule extraction, and it consists of 4 steps. So there are 4 steps on creating the lenticule which has been shown. So the first step is essentially the posterior part of the lenticule. The second is the side cut. The third is the top, which is called the cap, and the fourth is the entry cut. So this is what it is. Now just I'll be talking about it subsequently, but just look at this. This is a plano-convex lenticule. So this is something which is important because a biconvex lenticule has been introduced, and for which the amount of spherical abrasion, etc., that's being got is much less. Now these are the present machines that are available. Visumax 500, I don't think there's any specific talk on that, but Visumax 800, Dr. Shri Ganesh has talked about. Dr. Bharti has come. He'll be talking about the LDV, right, Bharti? You'll be talking about the Zemer.
Yes.
Yes, so he'll be talking about the Zemer. I don't think there's any speaker on ATOS, but I think there are 2 machines in India, if I'm not mistaken. 2 or 1? One is in NN?
Yeah, 2.
Second?
One in
Sorry? Anyway, so there is 1 or 2 machines. There are 2 machines possibly. A lot of work on the ATOS has been done in our neighboring country by Pradhan, that is Nepal. And then you have the launch commercial availability, which is on the Elita, which is the Johnson & Johnson system. These are now, I think, about 4 units, though the first patient that was done was in 2018, and that was on the flap, and then again it was India which did the studies. So both for Visumax 500, which Rupal was participating, and now 800, which Dr. Rupal Shah and Shri Ganesh did. I think Bharti has given a lot of data on the Zemer, and ATOS has come out of Nepal, and the studies on Elita have come out of the Indian subcontinent, that is Centre for Sight and then NN. So I think it's really proud that India is taking the leap forward in bringing on the table globally these lenticule extraction platforms. Well, the source of laser is approximately all at the same, that is 1043. Now, when you look at the pulse repetition rate, what you are seeing is that the newer lasers which are coming in have a higher repetition rate. That means that they move faster. So, if you look at the first one, which was the 500, it was only 500 kilohertz. You've gone up to 2, and you have gone up to 20, and this is 10. So, the Zemer can go up to 20. But overall, the time taken for the procedures has gone down significantly. So from 30 seconds, it has gone down to 10 seconds and 16 seconds. So these are the fastest lasers which are there, the Visumax 800 and the Elita. The energy per pulse has also significantly dropped. And if you see that the least amount of energy that is being dropped goes on to the cornea is only 50 to 70 nanojoules. And what does this translate to? This translates to clearer cornea day 1. It translates to better visual and a faster visual recovery, because collateral damage with a higher energy is obviously less. Now the patient interface in 3 of the machines are curved, starting from the Visumax as also the Schwind. So that kind of makes a little difference in the outcomes, and you have flat interfaces in both the Zemer as also the Elita system which is there. Cyclotorsion compensation was not there in the 500, but manually you could do it, but all these systems again are having cyclotorsion compensation, which could be manual or automatic, and centration system has been is there, which is again something that is required. Lenticular geometry, side cut, except in the Zemer, which I think Dr. Bharti will say, there are two entries, one which goes with the anterior plane and the other which goes into the posterior plane. And similarly in Schwind, the lenticular side cut is not there. So this is the clear, which is the corneal lenticular extraction by advanced refractive outcomes. I will not talk much about it, but this is what Dr. Bharti will be talking about. So this is the machine. The advantage of this is that this also has the femto cataract in it, and it is a portable machine. So this is the two advantages. The rest vis-a-vis how it works, etc., I think I'll leave it to Dr. Bharti. Visumax, you all know, this is a sleek looking machine, futuristic. This is the 800 which Shri Ganesh has shown you, and this is the centra line and the cyclotorsion compensation that you can have in this particular machine. Now let's come on to the place where I have done the maximum work, is the silk, which stands for small incision, or they prefer to call it smooth incision lenticule keratomileusis. It's a new investigational device, I would say, but this slide actually needs to be updated because it has got CE clearance. It is available in Asian countries, Korea, Taiwan, Singapore, Hong Kong, Australia, and it is now available in India also. The advantage of this is that it creates fast and smooth cuts for easy lenticular removal and induces minimal tissue disruption in the stroma which is there. And this, I think, I don't know how many of you were there in the live surgery, but this is what was shown yesterday also. These are two simultaneous images which you can see. This is a two-piece PI, that's the machine which you saw. The microscope is not inbuilt in the machine, so you have to have your own microscope. I think it's the same for Zemer, right? They don't have an inbuilt microscope. This is those who have worked on the intralace. This is pretty much similar to the intralace. It's a two-piece PI. You can see this is the PI which you use the grabber, and you can see that you bring down the entire machine. You go into the area where you have to now press on the grabber. You can see I'm opening the grabber, and once you open the grabber, you can see that the docking on the machine, on the eye or the cornea happens, and this is the applanation which is happening. If we go forward, I'll just show you. This is again, you have to mark the cornea centrally in the manual, and like in the intralace, in this spot, you can actually change. You can see I'm changing the centration. This is 0, 180, and you can see this is a cyclotorsion compensation that we are doing. So you have a mark which can be seen, and you can do the cyclotorsion compensation which is there. So once that has been done, the machine from a perspective of the laser, this is 16.6 seconds, as you can see. This is the posterior part of the lenticule. This is the side cut, and then you can see that this is the cap, and this is the entry cut that has happened, which has been completed. This is how it looks, and we are going to show you an OCT guided image. You can see that the entry is very, very smooth, because if you saw it goes over the entry, see how smooth it is. It goes over the entry pretty, it goes for about every 10 microns, it keeps going down. So if you have, it goes about 8 to 10 times. And then you can see here, this is the central mark that I was talking about. And you will see that the amount of dissection is negligible. So that is the thing. You can see these side marks which are there, and see there is hardly any dissection that you are doing. And what is the reason for this? The spot size is only 1 microns, and there is no spot separation, and there is no line separation. That means that they are adjacent to each other. I personally feel that maybe we can do a 1 micron spot separation, which can help. And you can see even the posterior one, which you can see even on the OCT. And this is very easy to kind of dissect out. And this is the lenticule which comes out, and on measuring, if I wanted a 6.2 lenticule, I will get a 6.2 lenticule, and you can spread it. During the study, there has been 0 incidence of any retained lenticule. There has been 0 incidence of any suction loss. As of now, and possibly in the future also, there may not be a rescue mechanism if you lose suction, because it's a biconvex lenticule. So both the surfaces of the lenticule are refractive. That's the difference as compared to a Visumax. So that could be a problem that you might have to convert it into a flap, or you may postpone it and do it subsequently. So these are the important things which, one is the dissection techniques have become less kind of difficult because there is almost zero dissection or negligible dissection that you have. Addressing astigmatism has been taken care of. There is, as of now, I would personally also wish the manual thing to go on to automated, as Shiri was saying. There is no circle software so far, and complications mean suction loss, which is there, which should look at that particular thing. Now, when you are looking at these lenticule assisted machines, this is what I'll just, because this is common for everybody, let us just look at what is known as the meniscus sign. This is for removal of the lenticule. I've just given you a brief overview of the machines. So if you see this, this comes like a meniscus. That means there's like a mouth which is opening when you are going into both the planes. So if you are going into the posterior plane, as you can see here, you can see that this is a meniscus that has been created, and this has been described by Tityal et al. From AIIMS RP Center. Now this is also a thing which has, this has been described by Susan, Jacob, etc. And you can see that this is called as a white ring sign. So this again, the white ring will help you decide that where is the posterior, where is the lenticule, the top and the posterior. So this is something. And then there is, this is, this has been described by Gitansha, Sachdev and all, et al. So this is, you can see when you go in into one plane and you go into the second plane, you can see, can you see this? This is stop sign. That means that there is a, it is not in the same plane, so you have a stop sign. So this is something that has been described. If you are in the same plane, then you will not have, then it will be. Innovative uses of lenticule, I'll just be talking about two things. This is tailored stromal expansion. What we have used the lenticule, again described by us, our group, is that nowadays there is adaptive fluence that has come. But when this was described way back in 2015, we didn't have machines for corneal cross-linking. Even now it is a Vedro basically, which is looking at doing adaptive fluence. There, if the corneas were thin, what do? You could damage the endothelium. So for the time when you are doing the cross-linking, at that particular time, we would put this lenticule of adequate thickness. So it is not like a contact lens that you are putting of a fixed thickness, but you are doing it of tailored stromal expansion. That means that if I need a lenticule of 60 microns or 50 microns, I could take a patient who was undergoing SMILE and use that, put it onto the cornea. And you can see this is just to show you that we always do epi-off. So you can see that we do epi-off, put the lenticule here, and then do the cross-linking. This is something, again, this is intracorneal ring segment implantation. We have used the lenticule. This has been published in AJO, and now it is going to be published, long-term results of intracorneal ring segments in thin corneas using SMILE lenticule for cross-linking. So this has also been used. This is Shri Ganesh, who is here. He has used the lenticule to actually work on hyperopia. That means that you have a myopic lenticule, you create a pocket and put that according to the power, as you can see here, and get good results with this. For this thing, again, for keratoconus to flatten the cornea, that also has been described as the use of the lenticule. So these are a couple of things. I think from a refractive standpoint, there is rapid evolution for the lenticular based surgeries, as also you can have innovative uses of the lenticule and get great outcomes for various other diseases. So the take-home points is that the world of refractive lenticule extraction is undergoing dramatic and drastic changes. Current platforms have upgraded and upcoming ones are on the horizon. And these have attracted more surgeons to shift to the lenticular-based procedures. If you look at China, if you look at Korea, if you look at Taiwan, if you look at Hong Kong, you look at Singapore, maybe Singapore to a slight less extent, but even all these countries, the go-to procedure is lenticule. The excimer laser is kind of required still to do hyperopia or for redo if you need, but that's sitting by the side. So that they have totally converted onto the lenticule, and in India also, I think the first lenticule procedure was done about 15 years ago. And the results are fantastic in the lenticular-based surgeries. So thank you very much for this particular presentation. Any questions for this or?
Thank you, sir.
Yeah.
Are there any questions from the panel or from the audience?
I think I just want to add to that comparison, Mahipal,
Yeah.
about the optics, how the optics of the Visumax is different from the other machines, including the Schwinn, the
Okay,
Zimmer, because Zeiss has a full field optic.
okay,
None of the other machines have a full field optic. They have partial field optic. That means you have various lenslets, because the manufacturing capabilities of creating such a big optic is not there with the other companies. So they have like a lenslet, which are partial field optics through which the laser is fired. Whereas with the
we can
Zeiss,
go up to 8 or 8.5, I
so
think.
yeah, not the zone.
I'm talking of both, like this.
No, it's the optics. I'm talking about the optics of the laser.
Of the laser, okay.
Optics
so
of the laser,
how does that
it's
translate
partial
on-
field, whereas Zeiss is the only laser which has a full field. So when the spots transition between the lenslets,
Yes.
there can be some irregularity, and that's what Zeiss says.
Okay.
With there, it's like a single optic. That's why the Zeiss laser is very heavy compared to the other lasers also, because it's got a very large full field optics. But again, regarding the spot size, even with the Zeiss, you can do a 1 into 1.5 micron, and then you can just pull out the lenticule. It comes out very easily. But the whole thing is that the visual recovery on day one, when you use a very small track and spot spacing, is not as good. We tried different spot spacing, right from 1 micron to 4.5 microns, and we found that the best was 4.5.
No, but were
by
were
4.5.
you wearing the spot size also?
We are wearing the spot and the track.
Okay.
And then
obviously.
we used multiple combinations. We looked at the scatter also, because when you look at the scatter, you know the quality of vision.
But aren't the spot sizes kind of fixed for machines? How can you
No,
vary
you
this?
can vary it. I don't know, some machines it may be fixed, but in the Zeiss you can vary it
500?
with 800.
No, not with the 500.
500 also you
Yeah,
can
I
vary,
think in
The
export
but not,
spot
one
size.
not as much. I think 500 you can just go
You
up
can
to,
vary the spot separation and the line separation,
yes,
but not the spot size per se.
not the
That's-
spot size.
Yeah, that's what I'm saying.
Spot size, only the spot spacing and the line
I
spacing.
agree, spot spacing and line separation can be separated. That we have been doing, that's to optimize the energy, but the spot size is fixed for a
Spot
machine.
size
so-
is fixed for
So
all
that's
the-
what I'm saying, the spot size I think for Zeiss is 4. This is, it's 4 microns, the
No,
spot
the
size.
spot size basically depends, because it's like the plasma which expands.
No, that's the expansion, but the spot that actually hits. So basically, that's what I'm telling the J&J guys, that if you are having, like typically what you have is a 4 micron spot for Zeiss and a 4 micron separation. So that's for the plasma to expand. Here they are giving no space between 1 micron and 1 micron. So what I'm telling them, for a 1 micron spot, please give 1 micron separation. There is a technical problem in doing a line separation, but a spot separation can happen, and that I'm going to start pretty soon to see, because that will further reduce the energy level. Okay.